Hello, everyone. I would like to welcome you all to this webinar series on global health and conflict offered by the Global Health Academy, part of the Global Health Institute at the American University of Beirut. My name is Omar Dewachi. I'm a professor of anthropology, social medicine, and global health. I'm the co-director of the conflict medicine program at the Global Health Institute here at the AUB. I'll be presenting the first talk in this series titled Introduction to Global Health and Conflict. Wars and conflict have been a defining feature of human societies and activities over centuries. Wars have actually catalyzed the rise and fall of civilizations, empires, and states, and have been one of the driving forces of social, political, economic, cultural, and environmental transformations. One of the main paradoxes of war is that while war has been associated with so much suffering, it also has been instrumental as a driver of advances in public health and medicine. Some more recent examples of this development has been the introduction of plastic surgery or development of the field of plastic surgery during the First World War to respond to the vast scale of bodily injuries, and another example is the popularization of the use of antibiotics among soldiers to prevent wound infections during the Second World War. It is interesting here also to point out that the establishment of the British National Health Service in the immediate aftermath of the Second World War as one of the examples of byproduct of the aftermath of that war. In fact, actually, historians of medicine have taught us that many advances in modern medicine have their origins in the military and in wars, and that they started eventually in the field of the military and eventually found their way to the general population eventually. Taking war as both a productive and a destructive force throughout history, my talk today will focus on how we could conceptualize and frame this dynamic relationship between war and what we call today global health. Let me start first here by exploring what do we mean by global health. So over the past decades, global health has become a buzzword used to replace or expand on other terms such as public health and international health. Much of such discourse has focused on the kind of the newness between two brackets of the global health, a terminology that seems to be connected to broader phenomena of health-related problems that transcend national borders and requiring state and non-state efforts. While there are definitely some newness to the state of our global health today, these problems and issues are not really that new. So historians have of global health have defined it as a collection of problems, institutions, people, initiatives, and diseases that are rooted in the past. In fact, historical forces and events from colonialism to structural adjustment policies to contemporary conflicts have all shaped the current state of global health. Thus, understanding this history of global health can help us to respond to the health challenges today. Although most global health workers are not really necessarily historians, but there is an important point here to make, that it's important to understand these historical forces and how they shape contemporary health problems. Some of the examples of the rootedness of contemporary global health epidemics in history are, for example, the recent Ebola epidemic in Western Africa. We understand that the epidemic in Africa was not just a mere biological event or that just caused a disease spread, but actually the emergence of the Ebola in West Africa, as many have shown, is attributed to the history of underdevelopment of health infrastructure and the failure of the global health efforts to do that. Another example is the current global antimicrobial resistant epidemic. While we began using antibiotics during the Second World War, and it has become the production of antibiotics and its use in humans and animals on a global scale has been attributed to the industrialization and the overuse of different kinds of antibiotics that has led today to our problem with antimicrobial resistance. Another example of this deep-rooted history is the complicated relationship between conflict and global health. It is important here to understand both that war and global health are historically intertwined. Such conceptualization is critical in shaping our present-day understanding of how conflicts shape present-day global health and how health interventions at the global scale shape the way conflicts play out. The rest of this talk, so I will build on my own research on the history of Iraq's health system to highlight this point and give an overview of the relationship between conflict and global health. Iraq represents an important case study of this intertwined relationship between war and global health, and much of my talk will be demonstrating this connection across history. As a medical anthropologist, my work has mainly focused on understanding the human, environmental, and global health consequences of conflicts. My interest in researching war and health stems from my own personal experiences of growing up and working as a physician in Iraq. During the span of my life, I've witnessed different incarnations of war in the country. The Iran-Iraq War in the 1980s, the 1990s, Gulf War and sanctions, and the 2003 invasion and occupation of the country, as well as the recent fallout of war against the so-called Islamic State. These experiences and my research in global health and public health provides insight into what I will be speaking about today. So my main goal for this presentation is the following. First, I want to show how global war has been central to both the history of the making and the unmaking of Iraq's healthcare system. In other words, I will try to illustrate how internationally waged wars were instrumental in the creation and sustaining of the country's health infrastructure as well as its dismemberment. Secondly, I will focus on the country's recent health crisis under decades of conflicts to highlight some of their global health fallout. Prior to the 1990s, Iraq was considered a leading developing country with major advances in medicine and public health. During the 1970s, Iraq was in fact on a rapid track of improvement of health and development indicators. Despite the political authoritarian rule of the Ba'ath Party at the time, Iraq was considered as a welfare state providing universal health coverage to its populations and free education to its all citizens. During this period, Iraqi medical schools and hospitals became a hub for students and patients from the region, where people flocked to Iraq to receive free medical training and medical treatment. This picture of healthcare and development in Iraq was quickly reversed in the aftermath of the 1990s Gulf War. From the 1990s onward to the present day, actually, Iraq witnessed a rapid dismemberment of the country's healthcare enterprise under decades of global conflicts and political violence. These decades of violence and global war and the global war machine have contributed to the destruction of the country's infrastructure, it has also led to massive internal and external displacement, large numbers of death, injured, and injuries and disabilities, and also has led to exodus of the country's health professionals. Also, moreover, there has been extensive environmental damage and rise of communicable and non-communicable disease across the country. This situation has also had many major fallouts across the region, as I will highlight in a little bit. But there has been a global failure also in the efforts to reconstruct Iraq's health care system in the aftermath of the 2003 occupation of the country. And all of these issues represent global health challenges that needs to be unpacked and understood in their own context. So it's critical here to see public health impact of these decades of war in Iraq as a global health story. It's global due to the impact of the global war machine that has played a role in the destruction of the country's healthcare, as well in the production of its regional and transnational fallout. Having said that, when examined through the guise of history, we realize that the story of war and healthcare in Iraq has always been a global story. War and conflicts have been central to the making and the unmaking of Iraq's healthcare. Modern-day Iraq was officially created in the aftermath of the First World War. During that war, the British Empire invaded Iraq out of fear of the Russian and German interest over the control of oil fields in the region. What was known as the Mesopotamian campaign in 1914 to occupy Ottoman Mesopotamia, what today we call modern Iraq, was originally devastating to the invading army. British Empire soldiers and officers suffered from myriad of diseases and health problems, including cholera, heat strokes, and diarrhea. In fact, most people died during the campaign from diseases rather than from the direct effect of combat. These losses defined the British early defeat during the campaign and ignited a major scandal where criticism was levied in the corridors of the British Empire against the dismal medical infrastructure of the British military. In fact, the Mesopotamian campaign played a central role in pushing major medical reforms in the British medical army, the Imperial Army during that time, to improve the evacuation of the injured and the sick, and to raise the morale of the troops. This is what historian of medicine Mark Harrison has called the medical war, to describe the major medical organization reforms during the First World War. During the 1920s, Iraq was put under the mandate of the League of Nations under British control, and one of the first attempts of the British to modernize the country was to build and expand the railway and road system to improve the movement of people and goods across the empire. These were seen as critical to the economic development of the country. Introducing of the faster modes of transportation led also to the acceleration of epidemic outbreaks. The famous cholera epidemic of the 1923, for example, started in the town of Abadan. And actually, before the British invasion of Iraq, the country did not really experience any major cholera epidemics. So the first cholera epidemic was introduced to the country with the British invasion. So the epidemic of 1923 started in the town of Abadan, which is basically on the border between modern-day Iraq and Iran, and it started among two Indian workers working in the Anglo-Persian Petroleum Company. The rapid spread of the epidemic to the city of Basra, and it's coinciding with the pilgrimage season to the Shia holy sites in the south of the country, raised many red flags and fears amongst the British authorities and the Iraqi authorities at the time. There were many fears that the epidemic will be advancing to the capital and possibly spill over to the across the region. At the time, the British and Iraqi authorities built on available resources across the empire to contain the epidemic. They borrowed cholera vaccines from India and brought samples from Cairo and expanded the production of these vaccines at the newly created central laboratory in Baghdad. The failure also of the quarantine system at the time pushed the public health authority to experiment with new methods of vaccination and use these networks of the empire, which we would see as transnational networks, to vaccinate the pilgrims and eventually control the epidemic. These events also, in time, defined how medicine and healthcare became central to the state-building project in Iraq. This translated into the creation of Iraq's first national medical school, the Royal College of Medicine, where many Iraqi doctors were trained locally and eventually acquired their subspecialties in the West and specifically in Britain. The movement of Iraqi doctors between the periphery and the metropole of the empire was seen as an important project, an important transnational project that defined the culture of medical training in Iraq even after independence. So until the 1980s, Iraqi doctors continuously were supported by grants from the Iraqi government and from the British government to go and specialize in Britain and actually return to Iraq to help in nation building. However, with the destruction of Iraq's healthcare in the 1990s, this history was very much of a driving force to push many Iraqi medical doctors to leave Iraq to the UK. From the 1990s onwards, thousands of Iraqi doctors entered Britain as asylum seekers and sought work in the British National Health Service, the NHS. This global health story of medical labor migration and the dismemberment of Iraq's human infrastructure were not simply defined by push and pull factors. They were actually an embodiment of a long-term history that goes back to the British colonial mandate after the country. Another example from Iraq, a fascinating example about the paradoxes of war, has to do a lot with the Iran-Iraq War. And the Iran-Iraq War, which was between 1980 and 1988, is considered one of the bloodiest wars of the second half of the 20th century. It's also considered as one of the longest conventional wars of that century. And it was longer than the First World War, longer than the Second World War. However, despite the massive suffering and losses from both countries, which mounted up to 1.5 million people killed and wounded, the two states witnessed a radical improvement in their public health systems. In fact, it has been shown that both countries used the war to mobilize their national populations to reduce infant mortality and maternal mortality rates. During that war, many international organizations, such as the UNICEF, were invested in major public health interventions to introduce low-cost primary healthcare interventions at the maternal and child health level. And these interventions also led to the increasing and the broadening of the coverage of healthcare into rural areas. And really normalizing and primary health care within these two countries during that war. However, this image of war as a driver of public health completely was transformed in the post 1990s war in Iraq, the first Gulf War, and the sanctions. During that period, Iraq was bombed by a U.S.-led coalition composed of 33 countries, and the military operations destroyed and targeted Iraq's infrastructure, including electricity, sewage and water sanitation systems, and transportation and communication. The military also, the coalition, experimented with new weaponries such as depleted uranium that had also unknown long-term effects on the populations and environment. The aftermath of the war was also even more devastating in Iraq because the international community also imposed harsh economic sanctions on the country that has been also described as a form of an invisible war. So these sanctions and the destruction of the infrastructure has led to the incapacity of the Iraqi state to repair its healthcare infrastructure and led to the rapid deterioration of health during that period. It also led to the exodus of many of its doctors and experts and health experts during that time. If we look at this table, for example, we can see how rapid and great the deterioration in the health indicators in Iraq. So, for example, the infant mortality rates increased from 1990 from 40 to 100 per 1,000 live births, and the same thing we can see with maternal mortality and with prevalence of stunted growth, malnutrition, and wasting. The effect of the 2003 occupation in Iraq was also similarly more devastating. So a lot of the times when people think about the war in Iraq, the effect at the aftermath of the 2003 in Iraq, we forget that there has been more than 12 years of war and sanction in the country that affected the country's health infrastructure and devastated the health situation prior to the 2003 invasion. And of course, if we see this global war in Iraq happening at that time, it even led to the exacerbation of population movement across state border. There has been massive internal displacement. And then what we have seen also is the movement of patients and doctors across state borders for people seeking healthcare in regional therapeutic hubs. And we have seen also a lot of disease, communicable and non-communicable disease outbreaks and unmet health needs. Moreover, the humanitarian response in Iraq has been very disturbing because it has been very limited and has faced many problems in dealing with the needs in the context of the country. So in conclusion, I want to come back to the main points that I raised during this presentation. I want to first bring back the issue that global health is not entirely a new phenomena. It has been rooted in historical past, and it's important for us as global health researchers and practitioners to understand how history shapes our present day state of global health. And the other point that I made in this presentation was that war and global health were historically interlinked, and these can be seen in the history of Iraq and the making and unmaking of state infrastructure and the state building. The final point that I want to raise here is that our global health, the global health fallout of war, needs to be seen as a complex matter. And it needs to be seen through interdisciplinary lenses, and that the response to that needs to take into consideration the changing biosocial and environmental realities of individuals, communities, and populations. And I thank you all for tuning in. We also would like to see from the audience if there are any questions. We have some time to do that, so please go ahead and ask your questions. Global health is not, I can't read it. So one of the first questions is by Francine Baker. Just for clarification, global health is not merely an extension of public health, but an interdisciplinary, multifocal, historically based discipline. I'm not really sure if this is a question or a comment, but I think both fields. I mean, I think recently we've noticed since the 1990s the rise of global health also as a discipline has been defined by different scholars, but it's definitely rooted in public health interdisciplinary research and work. And I kind of could turn you to some of the debates in the Lancet about the newness of global health and how it actually is. Global health in a way is public health, but in a way taking on a much more different shape and disciplinary clothings. Okay, one of the colleagues here in Lebanon has been asking, the question is, do you have any updates about the current efforts? Oops. Yeah, do we have any updates about the current efforts for public and global health at the level of Iraq, especially since we see a lot of patients at AUBMC, so we are noticing a high movement of Iraqi people for medical care across the nations. Yes, so this is something that I've done a lot of research on. I can refer you to an article that I wrote in The Lancet called The Changing Therapeutic Geographies of the Iraq and Syria Wars, where we discussed how the recent destruction of healthcare infrastructures in countries like Iraq and Syria, where very well developed history of healthcare has actually been playing out across the region through movement of patients across these therapeutic hubs. And so one reason we gave was the increasing militarization of healthcare in many of these countries. And the second point is the increase of what we call the regionalization of healthcare. And both of these forces have been pushing patients, or allowing them also to move across state borders to seek healthcare. It is interesting also here to point out that the Iraqi government itself has been invested in sponsoring Iraqi patients for a while, at least until the recent 2014 war, sponsoring them to seek healthcare or to pay for their medical care in many regional countries. One of them is Lebanon. You see many Iraqi patients in India, in Iran, in Turkey, and even in Syria before the recent unfolding of the events. Another question says, can you comment on the role of international organizations such as the WHO in promoting health and security and global health in war-torn areas? I'm not really with the WHO, but I think one of the WHO works usually with states, and that's been kind of one of the main tensions and limitations around that. There's also been recent controversies around the issue of the outsourcing of doctors with the WHO in the Mosul crisis, for example, which has raised a lot of points to what's going on in the region. But of course, the WHO's main role is to provide technical assistance to governments to build their healthcare systems. However, it's been very difficult in a place like Iraq because of the security situation across the country and the continuing violence for any kind of efforts to really take shape. And this is someone maybe in the future we'll have someone from the WHO who can maybe answer to these specific questions. Okay, so this is a very good question from Amit. Could you share, the question goes, could you share an example of a health research question that is specific to conflict settings, that is unique from research questions for other low and middle income country context? How is health research in conflict setting different from research in more stable settings? This is very, very good question, and I think some of my colleagues in the next webinars will be addressing them on a multiple level in terms of mental health. For example, there is very different ways in thinking about mental health in war settings because of the exposure to high rates of violence, for example, the effects of polio vaccinations and the effects of the kind of collapse of vaccination infrastructures in many of these countries during war, and the access to that has been also one of the main questions that we saw happening in the Syria conflict, for example, the polio epidemic that emerged in the country. In Iraq also, there has been, and in Syria and many conflict settings, there has been higher rates of also multi-drug resistant bacteria seen among the wounded. So actually, one of the main health problems and health research in the conflict area is around wounds and wound injuries. They become much higher. You see much more wounded populations in war settings, and the management of these cases are become very complicated, but because they require long-term supervision and healthcare and all of that. So what really is important here is to understand that this is something has to do also with the changing nature of these present day wars. Previously, let's say in the Iran-Iraq War or in the First World War, Second World War, most of these injuries were really defined by military medicine. But what we see right now with more urban warfare, with the civilian, with more effects of these wars affecting civilian populations, we see civilian hospitals and humanitarian hospitals taking the main consequences of these wars. So this is one of the things that we've been doing here in our research, is to use this kind of notion of war injury as a both lens into understanding the broader consequences of war, but also to address a rising problem that has becoming much bigger in the clinical load that doctors see in their everyday practice. So, and Sam asked the question, non-communicable diseases are at an alarming rate worldwide. Do you see that war has an effect on their prevalence in the MENA region? I think definitely yes. I think this has to do a lot with the failure of early diagnosing of these cases because of the collapse of the healthcare infrastructure. People maybe don't have access to healthcare. There's a major problem with displacement and populations that probably don't have necessarily good access to non-communicable diseases, and this is a kind of a big problem that many of my colleagues and researchers will address in the incoming seminars. So that's one aspect of it, is the kind of the collapse of the healthcare infrastructure. But the other really big problem, I think, that has been under research is the increase in toxicity of the environment, the environmental causes that is caused by war has been one of the really understated problems that hasn't been really researched well. So we don't know if what we see in terms of the increase in cancer rates or the increase in other non-communicable diseases has to do a lot with the toxicity of the environment. Moreover, there are many triggers like trauma and stress that could actually be contributing to these issues. I'm more than happy to answer more questions. We have some time left here. Well, thank you everyone for tuning in for this first webinar series. I really encourage you to tune in for the series, the rest of the series. You'll have information on that on the website. And I thank you all for listening to this conversation.